Welcome everybody. My name is Mark Boyd. I'm the Chair of Medicine from the University of Adelaide, based as a clinician in NALHN, and I'm very pleased to be able to present to you two researchers from NALHN from the Division of Cardiology. Before any further ado, I would like to acknowledge that NALHN acknowledges the Kaurna people as the traditional custodians of the land where we proudly work and deliver health and wellbeing services. We also honour Kaurna elders, past, present and emerging, and we recognise Aboriginal cultural authority and their ongoing spiritual connection to country. Just the housekeeping before we dive in, could please, if you have questions, which we encourage, could you please type them into the Q&A section of Zoom, and I will be responsible for asking speakers these questions, time allowing. We have two great presentations from colleagues in NALHN, and I'm delighted to introduce the first of them, which is Dr. Melanie Wittwer, and the title of which is Investigating the Link Between Obstetric Health and Future Cardiovascular Disease. I should remind you that the session is being recorded and will be available on the website shortly after. Melanie.
Cool, I'll just share my screen.
Yeah, please share your screen.
Beautiful. So thanks for the introduction, and thank you to everyone for joining me as I give you a brief snapshot into our research group up here in the north. So we're the Northern Cardiovascular Research Group, and we're headed by Associate Professor Margaret Arstle. She's a clinical academic with the University of Adelaide and also the Director of Cardiology within NALHN. So we're still a fairly young emerging group, but we do now have 4 postdoc / study coordinators working in our team. We have 3 current PhD students and 2 honours students. So our research that we're doing is mainly clinical. We do have access to a beautiful lab here, so if anyone would like to collaborate on some more basic research, please get in contact. So where did this all start for our group? Well, this is a very, very old figure now. It was published in 1999 by Baccarino et al. And it shows the rates of death during hospitalisation for myocardial infarction or heart attack among men and women. So you can see men are in the light grey bars and women are in the dark grey bars. And in the older ages, the mortality rates are similar between the sexes. But what's most concerning is when we look at the younger ages, women aged less than 60 years are almost 2 times more likely to die in hospital after an MI compared with men. So you may say to me, well, this is a really old slide. Surely we've made a lot of progress in this area. Surely there's no gender disparity like this anymore. But unfortunately, even more recent research from within Australia shows that female sex is still an independent predictor of mortality after MI. So what can we do about this? This is what we've been asking ourselves. How can we reduce this mortality gap, this treatment gap? But probably more importantly is how can we prevent women from even having an MI in the first place? Unfortunately, there is an event that is unique to women that occurs relatively early in life and can be used to identify high-risk women, and that is pregnancy, the window to future cardiovascular health. What we do know very clearly from the literature is that women who have a pregnancy complicated by preeclampsia, gestational diabetes, preterm birth, or deliver small babies are at a 2 or more times increased risk of developing cardiovascular disease later on in life. So what this kind of looks like is, if you look at the green line on this chart, this is the lifespan along the bottom. The green line is the threshold for clinical, vascular, or metabolic disease. Now, a normal healthy lady in the blue, she may have a few blips when she's pregnant because there's a lot of demand on the cardiovascular system and may develop cardiovascular disease later on in life. In contrast, the group in red develop clinical things like preeclampsia, as I mentioned, during their pregnancy. They cross that threshold. And as you can see, they develop clinical disease such as hypertension, cardiovascular disease later, earlier on in their lives. So what are we doing to investigate this link? So we can either perhaps maybe look at pregnancy events and see how they predict premature or mature cardiovascular disease, or we could even look at women who have cardiovascular disease and to see whether they had any significant pregnancy events. And the second one is exactly what one of our PhD students is doing here. So he's done a unique project with SANT Data Link. It's the first of its kind in Australia. We just have no information like this. It's a retrospective age-matched case control study. So he's identified women with premature coronary artery disease from CODOSA, the Coronary Angiogram Database of South Australia, which is headed up by Professor John Baltrami. He's identified healthy control women who are age-matched from the Northwest Adelaide Health Study. And then he's linked that with the perinatal statistics. Excuse me while my light goes out. And very preliminary data yet. He's submitted an abstract to the American Heart Association and we'll present that later this year. But we have found that, or he's found that women with premature obstructive coronary artery disease are at a more than three times likely to have a pregnancy complicated by gestational hypertension, preterm birth, and low birth weight. So amazing research, really highlighting the importance of this group of women. So Prabha is one of our other researchers. Her focus has then been maybe on the more pregnancy side. So she's looking at pre-pregnancy and pregnancy cardiovascular risk factors and whether they can predict whether a woman will develop preeclampsia or gestational diabetes. She's also heading up our cardiorenal registry. So it's the first registry for the state, which is looking at cardiac and renal disease within pregnancy and following up those women. Melissa is just finished her PhD. She's looking at mums and kids 3 years postpartum and looking at cardiovascular risk factors in those cohorts, specifically with respect to gestational diabetes. Now, I've talked about looking forward from pregnancy to premature cardiovascular disease. And I guess with all the information that we've gathered so far, one of the main things we want to do is identify if there's a target for intervention. Is there something we can do in the meantime with all this knowledge to kind of reduce this risk in women who have a complicated pregnancy and maybe even make it so that their subsequent pregnancies and their cardiovascular disease occurs at a later onset. So Emily Aldridge has just finished her PhD. There's a lot of us at the moment. And during that, she developed a postpartum lifestyle intervention clinic. It was established in 2018, and it's a nurse practitioner-led clinical service that we provide here within NALHN. It does have a research component to it as well, and women are seen at 6 months and 18 months postpartum. Very briefly, one of her big findings was that at 18 months, we've shown an improved rate of metabolic syndrome in these women. There's obviously a lot of more research we can be doing in this space. So if you are interested in collaborating, do get in contact. I've got our contact details at the end. Now we do a lot of other different, more cardiac specific research. Where do I fit in? I have looked at sex differences in out of hospital cardiac arrest, and we find that men and women are very different in their biology. That determines what kinds of cardiac arrests they get and then what their outcomes are as well. And we do a few more basic cardiology projects as well. But if you are interested in collaborating with us, we would love to hear from you, particularly within the realm of basic research. We have undergraduate and honours projects, PhD projects, and please contact Melissa or myself if you have any more questions. I'll stop my share. Thanks, Mark.
Thanks very much, Mel, and really interesting presentation and you know, clearly a lot of activity going on in that space, a very interesting space, I think, at NALHN. Let me just look at the Q&A. I don't have anything in the chat. I don't, but I do have a question. I was very interested in, well, I was interested in everything, but the postpartum intervention clinic is targeting metabolic syndrome, right, in women who've given birth. So how do you enroll those patients? Are they how do you select them for enrolment, and how many do you follow? Do you know? I know.
Yeah, sorry. I should have given a bit more detail there. So it's women who have a high-risk pregnancy, so any medicated preeclampsia, gestational diabetes, placental abruption, they're automatically, they're referred by our clinicians down in obstetrics, and then referred to our nurse practitioner, and then she follows them up. The reason why we had a focus on metabolic syndrome is because the women are so young, there's no actual cardiovascular risk score that we can use. So we're using metabolic syndrome as a kind of indicator of risk for vascular disease.
Okay, and so those women, some of them would have a normal BMI. You're not basing it on people who maybe are at greater risk for metabolic syndrome?
Correct, yeah. So there's some preeclamptic women who have normal BMIs. Right. I must say our cohort does have the larger BMIs anyway.
Sure. I mean, that's a fact of NALHN. I think something close to 50% are probably overweight or obese. Yeah. Lastly, I mean, are there specific interventions, or is this really more about following people and documenting the changes in various metabolic syndrome variables over time?
No, so there is an intervention. So our nurse practitioner she's a cardiac rehab practitioner as well. So she takes them through diet and lifestyle counselling. We go through a whole raft of questions with them, and then she provides like a tailored plan for them. Okay,
and yeah, really interesting research. You take that out how long? How is it ongoing, the follow-up, or is there a certain cut-off time?
No, because it's part of our clinical service. It will be provided as long as we can. We're hoping to get more FTE to offer it to more women as well. We can really only reach like a very small proportion of our patients.
Sure. I do have a question from Leanne March, which is there a possibility of general practitioners becoming involved with referral or education information that they can receive to ensure at-risk women are followed up or referred to the service outlined?
Yeah, so with regards to referral, I think at the moment we can only take referrals from within the hospital, mainly because we're just overwhelmed at the moment. Yeah. And we are working with a group called Her Hearts to develop some educational materials which will be available online, and maybe we can get in touch with GPs.
Okay, all right, look, that's terrific. Let's leave it there. Hang around if you can, because there may be other questions that people think up in the meantime, but it now gives me great pleasure to introduce a good colleague of mine, Rajiv Mahajan, who's in the Division of Cardiology and specialises in electrophysiology. He's Associate Professor Rajiv Mahajan will present now on new frontiers in the management of atrial fibrillation. Rajiv.
Thank you, Mark. So over the last few years, we've built up a small research team, and with your help, Mark, in our group, we have 2 PhD students. Thea is finishing off a preclinical PhD. Rakesh has just started off, and he's working on subclinical AF and cognitive function. I'll be presenting some of the work from Bhavya Garg, who's just finishing off honors. We have clinical trial coordinators headed by amazing Gabe McMichael, who's been helping coordinate all the studies. And Tim has been working on the Precision AF project, which I will be mostly talking about today. So today I'll take the opportunity to present some of the preclinical work, not the preclinical, the pilot work that we've done leading to this project. So as a background, AF is the most common arrhythmia in the world. Atrial fibrillation is associated with a 2-fold risk of heart failure, 2-fold risk of all-cause mortality, and 5-fold risk of ischemic heart disease. The figure over here shows data from the Framingham Heart Study, and essentially shows that people who are without AF at age 55, 65, and 75, they have nearly 1 in 3 risk in developing atrial fibrillation in their lifetime. We spend a lot of money on hospitalizations in patients with atrial fibrillation. We spend around $1 billion every year. This is the data on hospitalization for the 3 major cardiovascular causes: atrial fibrillation, heart failure, and MI over the last 20 years. Heart failure shown in red, MI in green, and AF in blue. And you can see that the heart failure hospitalization seem to have evened out with very little increase over the last few years. Myocardial infarction, a bit more increase, more so ever since the addition of troponins to the definition. But atrial fibrillation over the last 20 years has been steadily increasing and has become the major cause for hospitalization now in Australia. And the reason why AF is so difficult to manage is that it is a electrical disease, abstract and difficult to understand, and the management quite complex. The treatment consists of oral anticoagulation, rate control, and rhythm control in specific patients. And over the last 10 years, with work coming from Adelaide, lifestyle changes, which adds another component to the treatment, which makes it very complex. This is data from a survey performed by the AWARE AF group, which was a collaboration between multiple groups, multiple associations interested in AF, which included the European Heart Rhythm Association as well. And what they found was that patients found it difficult to understand atrial fibrillation, and the doctors found it difficult to treat patients with atrial fibrillation. And they interviewed around 800 patients and 800 practitioners in 9 countries. And this is data showing patient-reported feeling about atrial fibrillation. So 1/3 of the patients either felt afraid or worried about their cardiac condition. They were worried that they will die. And both patients and the physicians reported quite adverse impact on their quality of life and ability to carry out their day-to-day activities. The same survey also looked into the patient knowledge about atrial fibrillation, and shown here in red is what the physicians felt the knowledge was, and that was, and the bluish green, what the patient's perception was. And this asked them to score it on a Likert scale of 1 to 5, with 4, 5 familiar and 1 to not familiar. And you can see here across the range of whether it's complication, benefits, or understanding of AF, or treatment for AF, or progression of AF, the knowledge regarding atrial fibrillation was quite unsatisfactory. This data shows the physician satisfaction, and it essentially shows if the physicians feel that the educational materials are inadequate. And they've compared it across the different cardiovascular and non-cardiovascular disease. Among the cardiovascular disease, AF was the worst, with nearly 60% of the physicians felt that the educational material was not adequate. Patients usually used specialists and GPs for as the main source of information, and half the patients were actually searching for more information about AF. So health literacy has been considered an important way to actually improve outcomes. The hypothesis is that you need to health literacy intervention that can lead to behavior change and ultimately improve health outcomes. So this is a systematic review which looked into studies which did an intervention and looked into pre and post health literacy with the intervention. And then some of them reported on behavior outcome. So of the 22 studies which looked into whether the intervention actually made a change in the literacy of the patient, only 8 reported on behavior outcome and none reported on long-term health outcomes, suggesting that the data in this area is still at best needs more better data. 18 of these studies had high risk of bias, Only 2 were performed in cardiovascular disease. And what was glaring was there was a lack of disease-specific health literacy measure for assessing change in health literacy, and the intervention was not defined. So our current research in precision health at NALHN is a precision AF project where we're using health literacy and precision instruments to help guide, manage patients with atrial fibrillation. The reason and the hypothesis is that this would be scalable as compared to the other alternative models that we have. So this project will be consisting of developing the AF app, which we are doing at the moment, beta testing the app, and then clinical trial to look into change in health behavior and cardiovascular outcome and do the health economics. So we have collaboration across we're at 3 universities and CSIRO, and the 3 clinical sites where the studies will be done would be Balmacewen Westmead Hospital in Sydney and Austin in Melbourne. So what I'm going to present today is some of the pilot work that we did leading up to this project. And this is the first step was to develop a AF-specific health literacy patient outcome, patient-reported outcome measure. And the aim was to develop this instrument and qualitatively validate this. So our research team brainstormed with the aim to have the construct as the AF-specific health literacy. The target population was people living with atrial fibrillation. We chose 5 domains which we thought was important for patients to understand about their disease, which is what is AF, what are the symptoms, why do people get AF, what is the management of AF, and what measures can slow or prevent progression of AF. So this went through the initially expert advisory group and then consumer advisory group. Each of the groups, both these groups were asked 27 question semi-structured interview looking into face validity, whether these items, what are these items measuring, content validity, whether these items that we've talked about, do they actually cover the information that is required for AF patients, item clarity, will the patients understand what the question is being asked, acceptability, whether the patients would be comfortable answering this, and whether the questionnaire is the appropriate length. So the data was collected by a neutral facilitator and it was transcribed. And finally, we had 47 items in the final questionnaire. So the setting was Balmacewen Hospital. These sessions, the expert and the and the consumer advisory sessions were 1 to 2 hours each. In the expert advisory group, there were 4 medical experts, 2 nursing experts, and 1 physician with interest in social determinants of health. In the consumer advisory group, there were 4 participants living with AF and 3 members of the community, 2 of them from the SA branch of the Heart Foundation when they were there. And the final version had 47 items, 5 domains, 13 items were removed as part of this process and 13 new items added. So what did the expert advisory group add? They added more of content to the questionnaire. So they also thematically they replaced AF patients with atrial fibrillation. They also split the question on blood thinners, reducing stroke risk, and whether the AF progression can be prevented. What should, if a person has an acute AF episode, should they go to the emergency? And few other things, content was added. The consumer advisory group, on the other hand, helped improve the face validity and also the item clarity. So they asked us to replace the Likert scale with a 3-point response scale and replace medical practitioner with health provider. And they also asked us to use lay terms followed by medical terms. For example, electric shock followed by cardioversion brackets so that the patient understand things better. So summary of the questionnaire: 47 items, 5 domains, 3-point response. They were correct responses as true for 33 items and false as 14 items. We've we've used this in our record AF registry, and this is a sample data from our specialized AF clinic on 100 patients who have now done this questionnaire. The mean score was 33 out of a maximum of 47. The literacy was least in why do people get atrial fibrillation. The most common misconceptions were that aspirin reduces AF-related stroke risk, which is not true, and that the patients should go to medical emergency always if they have an episode of AF, and patients with permanent AF cannot work full-time, which is incorrect. The questionnaire also demonstrated poor correlation with functional health literacy, which means that if an intervention is being performed, as in our specialized AF clinic, we do the education, that even if the functional literacy is not a predictor whether the AF specific health literacy will be high or not. So to conclude, this is a questionnaire which incorporates risk factors which have never been incorporated in the previous health literacy questionnaires regarding atrial fibrillation, and this questionnaire can help with personalized management guided by gaps in AF knowledge in individual patients, and also inform on strategies to improve our clinical service. So, Mark. Thank you.
Thank you very much, Rajiv, for a very interesting exposition. And I think one of the things I really appreciate about this work is how you have adapted it to, the understanding that in the North we do serve a quite disadvantaged and often not particularly literate population compared to the other networks. So it's really work that speaks very much to the people we serve. I'm just thinking. All right, I actually have got a couple of questions for you. And one of them was, you showed some interesting data at the beginning regarding patient and physician degrees of knowledge about AF. And I guess what, I think this is obvious, but I was thinking at the time, it's presumably the physicians is a physician's understanding of what they think their patients understand compared to what the patients reported themselves. Is that right?
Yep.
Yeah. Okay. Fine. Thank you for that. What accounts? I was very interested in the early graph on ischemic heart disease, heart failure, and AF. I mean, AF has this inexorable rise, and as you say, some of the others pretty much, it's hard to make, which is good news, I guess. But what do you think accounts for the AF? Is that because we've just focused less on that than we have ischemic heart disease and heart failure in terms of intervention?
Yeah, look, I think from the heart failure point of view, it has stabilized with the increase in treatment that is available, and also the changes that have happened and the heart failure clinics that have started with the heart failure nurses. With the atrial fibrillation, I suspect it was kind of underreported and neglected, and it is becoming more apparent. And as the population is aging, we have more and more patients presenting. Along with that, there is more people are actually recognizing AF. But it's very difficult to figure out what are the main reasons, but this is what I would suspect.
Okay. All right. So interesting work to be continuing on with, I guess, and part of it will be how, I think you mentioned at the end, the personalized, how do you get precision sort of medicine, understanding each person's understanding of the illness, and then how do you actually go ahead and try and improve that in time. I don't know if you want to mention how you might approach that or work that's continuing from this.
Yeah, like I said, this is just the initial pilot work that we've done as part of the Precision AF project that we are creating, and it is a large collaborative project, as you know, involving CSIRO and University of Sydney and University of Melbourne. There's also scope for further collaboration, and of course, there's a scholarship available for a PhD student as well. And we do have a PhD position for a registry where we are collecting health literacy data. And I think what it fits in, this is just a measure which can be utilized, looking into where the deficiencies are and where to inculcate critical health literacy, and also help people self-manage their disease. And the main aim is to actually be able to cut down on the on the burden on the clinician to be able to actually still deliver the same care in the absence of integrated clinics, which may not be available to everyone.
Great. All right. Thank you. Look, we're nearly out of time. We are pretty much out of time, and I know everyone at 5 o'clock probably wants to head home, including the presenters. So with that, I'd like to bring this session to a close. Just for your information, if you have feedback, comments regarding the session format or the presentation of the ABMC research mini reviews, you can please, we'll leave up the Q&A function for the next few minutes. If you want to give us some feedback, that always helps us improve the quality. And also the session presentation, as mentioned at the beginning, will be uploaded onto the ABMC website in due course. With that, I'd like to close the session and thank our two excellent speakers and look forward to seeing you next time. Good evening.